The video series Better Disease Management was developed by the Georgia and Oklahoma Academies of Family Physicians as a part of the Go Diabetes Initiative. The Better Disease Management series consists of 7 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
So how are we doing? And this is just a rhetorical question, but how are we doing as a nation, as a country, when we come to taking care of our diabetics? This is some older data from '88 to 2002 by the National Health and Nutrition Education Survey. Over this time frame, now remember this was in the era of landmark diabetes studies, DCCT, UKPDS trial, and what we found is based on this database was that blood sugar didn't really improve, blood pressure didn't change. There was some improvement seen in the treatment of cholesterol, aspirin use, and vaccinations. And so if you're concerned about public health, you have to ask yourself, well, why? I mean, we saw in the UKPDS just a 10-point lowering of blood pressure reduces somebody's chances of dying by 33% within that time frame. And so why? Why can't we do any better? Well, it's, diabetes is not glamorous to treat. It's so nice when you have somebody that comes in with a urinary tract infection and you can give them ciprofloxacin and 2 days later, gosh, I feel so much better. Or a strep throat and you give them amoxicillin and a day later they're like, man, I feel so much better. Thank you so much. People don't say that with diabetes, They just don't say that. It's not glamorous. It's a chronic disease. It comes with a lot of comorbidities that we have to address. And so the same enthusiasm that a patient has when they're diagnosed tends to wane with time. The enthusiasm of the clinician when they first diagnose somebody tends to wane over time. It's like, you know what, are you making sure that they go to the doctor, or eye doctor every year or two? I think, gosh, it's been 5 years and I haven't seen them. Well, that's not good. You just tend to lose track of all these little small things that have been shown to be helpful. I think the biggest thing is a lack of team approach. Ultimately, it kind of falls on my shoulders and your shoulders. If you order the test, if you make the referral, if you do the foot exam, if you order the pneumococcal vaccine, if you order the flu vaccine, it happens. But in the average patient visit, the patient's complaining about their allergies, about their depression, about their osteoarthritis pain, and you're like, how can I remember to address these 2 or 3 things? The patient didn't come in for diabetes or wants to know that, doctor, I came in for my nasal congestion. Why are you sending me to the eye doctor? How often have you had that question? But what about if your receptionist or your nurse said, you know what, doctor, I saw that that patient hasn't been to the eye doctor in the past 2 years. I went ahead and made the referral. You'd be like, thank you. Thanks a lot. And there's ways and strategies of doing that. And then finally, we have a very reactive patient care model. The patient shows up and they actually are there with a chief complaint to follow up diabetes. You might have a chance at accomplishing the things that we know improves outcomes. But they don't show up with that. They show up for the things I just mentioned. And so we're often left bringing these things back to the forefront the patient's not as concerned about. This illustrates the point. This was a study published in Diabetes Care that involved 2 academic medical centers, perhaps a center like maybe where you practice. This was in 2 academic medical centers, one in Brooklyn, one in Detroit. And it showed how they did with their patients who had diabetes as far as achieving the standards of care. A1Cs less than 7, about 1/4 of them. LDLs less than 100, about 1/3 of them. Look at the very bottom. People who had high blood pressure, who had high cholesterol, people who met blood pressure guidelines, cholesterol guidelines, A1C guidelines, and were on aspirin. Only 2 people out of 100 in their patient panels that had diabetes were meeting that. And so these were kind of the ivory towers, you know, of academia, where we have diabetes educators are actually on staff, where we have time, where we have, you know, all these resources where people can go and plug into. And so, let alone the private clinician who's there with whoever helps him or her, and so it's just hard to really meet all those guidelines. It may make you think, man, maybe if I'm a family doctor, I shouldn't do this. But that's not, I think that, and I bring this slide up because I want you to feel compelled as a family physician that, number one, it doesn't matter if you want to, you're going to see a lot of diabetic patients, okay? 90%, 9 out of 10 diabetics are going to come to you for their care, okay? Now, only 3% of internal medicine graduates practice general internal medicine whenever they graduate, okay? And believe me, that other 97% that's going on to subspecialize, they're not choosing endocrinology, all right? They're choosing, you know, the ones that have dollars attached to them, and endocrinology is not the one. And so primary care, we have to embrace the role that we have as primary care physicians to take care of these patients. It's really an opportunity to establish ourselves. You know, you've heard about the future of family medicine, you've heard about transfer med, you've heard about patient-centered medical home. Well, here you go. This is it. This should be your medical home when you take care of these people. They're going to come see you, so embrace it and put together systems that work and work well. Now, here's a bit of encouraging news. The care that you and I provide for these people seems to be just as good as what endocrinologists provide when you look at functional status, when you look at outcomes and how long people live. There's really no difference in patient populations that are treated by subspecialists versus specialists. You're a specialist, okay? You specialize in family medicine. So remember that and embrace your role. There are some things I think we can learn. Perhaps what we could do is have like 2 days a month that we have this half day I'm going to see my diabetic patients. And you get your nurse, you get your receptionist on board, you tell everybody, okay, this morning we're doing diabetes, look at the charts. Have they had urine microalbumins? Have they had foot exams? Teach your nurse how to do them, to get those things set up and so that you can actually accomplish all the things that have been shown to improve outcomes.